Hello everyone and welcome to today's webinar, Medicaid PPS 101 for Everyone. I am Luke Ertl from the Division of Public Policy and Research at NAC, and I'm pleased to bring you this webinar on PPS with my colleague Susan Sumrall. Before we get started, let's review a few housekeeping items. You have joined this online event by calling in. All the lines have been automatically muted. The duration of this webinar is approximately 90 minutes, including presentations and Q&A. At any time during this webinar, if you would like to ask a question or make a comment, please use the chat feature on the lower right-hand side of the WebEx window, and please reference the slide now on your screen. Select Send to all panelists and simply type in your question or comment and click Send. Your message will come to me and the panelists. The other speakers I will answer your question as soon as we can, and if we cannot get to your question, we'll follow up with you after the webinar. Let us remind you that today's event is being recorded and will be available online within the next few days on the MyNAC Learning Center. I will now turn things over to Susan.
Thanks, Luke, and welcome everybody. It's great to see so many folks interested in the Medicaid PPS 101. I am going to go ahead and get to our slides. And we'll go ahead and get started. So today we really are going to talk 101 level. We're going to cover the basics of Medicaid and the basics of health centers. We're going to talk a little bit about the history of the Medicaid FQHC PPS, how we got where we are today and why that's important. Then we're going to talk a little bit about the mechanics of the FQHC PPS, how it works, what's in, what's out, that type of thing, and then common FQHC PPS myths. We often here at NAC get a lot of questions that are based on sort of misconceptions about the FQHC PPS, so we thought it might be a good idea to talk through some of those. One thing I do want to note is that this webinar is going to focus on the federal requirements in Medicaid. I used to work with somebody on Capitol Hill who, when you would ask a Medicaid question, they would say for which state, for which population, and for which service, because depending on each of those things, the answer could be very different. I think probably each state could have its own PPS 101 webinar, but for today, we're going to stick to the federal requirements and the federal perspective here. Before we get started into the meat of the presentation, though, I want to go ahead, we're going to do a quick poll. We're curious to see who's here today. Are you with a health center? Are you with a primary care association or another group? So I think Luke's going to open up a really quick poll. I will tell you, this is not the only poll we're going to have today, so please stay tuned and help us out with our poll. So take a second right now to let us know who you are. Great, Luke. I think we can go ahead and close the poll now, so we can see sort of who's here. We'll get our results in any minute now, and we can move along. So let's get started. This is really we're really going 101 here. We're really starting at the basics. I think it's good for us to all start at the same place. Oh, and there's our poll. It's great to know. We've got a lot of health center folks on the line, which is wonderful. A couple of providers, which thank you so much for taking the time out of your day to be here today, and primary care staff and others. Thanks so much. It's good to know who's here. And like I said, though, we really are going to start with the basics. We're going to start at the very beginning with Medicaid. I think it's helpful for everybody to have the same sort of understanding as we move along through this webinar. So obviously, I think most folks probably know, but if you don't, just in case, Medicaid is a health care program that is created to assist low-income families and individuals paying for their health care costs. It was created in 1965 along with the Medicare program happens to be also about the time that the health center program was created. So we all sort of share our roots in the same beginnings. Medicaid is a joint federal-state partnership, and what I mean by that is that it's a program that is partially funded by the federal government and then partially funded by your state government. In order for a state to receive federal funds, there are a number of requirements, but that they must meet, and then the state also can make some of their own. But some of you, when you're talking about Medicaid, may have heard somebody mention the FMAP, or the Federal Medical Assistance Percentage. Basically, that is just a way to show how much is the federal government contributing towards the state's Medicaid program, and then the remainder is what the state contributes. And that varies across the board, for sure. So if you hear FMAP, that's just a way to talk about the federal government percentage. Also worth noting that Medicaid may go by a different name in your state. Not everybody calls their Medicaid program, you know, the state Medicaid program. They may have different names. If it's something you're not familiar with, or you're not familiar with what Medicaid is in your state, I think a quick Google search could help you out there, or your state primary care association. And then finally, just generally right now, Medicaid is covering about 72 million beneficiaries nationwide. So I mentioned the joint state partnership here, and I think this slide we're going to talk a little bit about what makes it, how that actually works in practice. The blue square or rectangle represents all of the federal requirements. So like I said, the federal government has said, the law says if a state wants to participate in Medicaid and wants the federal government to assist with that, you must meet the federal requirements. Today, every state has a Medicaid program, and including the territories and DC, there are 56 different Medicaid programs in total. So that means everybody's following the blue square requirements. Just so you know, the mandatory populations, pregnant women and children, up to 138% of federal poverty level, and those individuals who are receiving supplemental security income, SSI payments, are your mandatory populations. The mandatory services are things like inpatient services, inpatient hospital services, outpatient hospital services, physician services, home health, labs, nursing facilities, tobacco cessation programs now, and something called early and periodic screening diagnostic testing for kids, EPSTD. The most important thing for this conversation today is that FQHC services are considered a mandatory service. So in this whole conversation, I'll reference back to this slide, the blue rectangle, yellow rectangle, or green rectangle. The health center provisions or health center services fall under the blue rectangle, along with our payment methodology. So then a state has the option, they must cover that base package, and the state can come in and then add additional populations. Maybe they're going to increase the percentages of federal poverty level up to a certain point. Maybe they're going to increase the services that they're offering, things like dental or drugs or optometry. Those are the most popular ones we hear, but definitely not an exhaustive list. There are many more optional services that a state can add on. Also, I think Medicaid expansion from the Affordable Care Act right now is considered an optional benefit based on the Supreme Court ruling. And so states can choose to add non-elderly individuals up to 138% of federal poverty to their program if they would like to. So taken together, your blue rectangle and your yellow rectangle create your own Medicaid program. And like I said, there are 56 different Medicaid programs right now. Probably each one could have its own webinar. But today we'll be talking mostly about what falls in the blue rectangle. There are a couple of what we call sort of Medicaid buzzwords that I think are probably things that you guys are hearing in conversations either in your state or at your health center or even on the news. And so we want to take a couple minutes to go over some of those. Not going to get into any policy discussion on any of them, but just wanted to give you an overview, a definition to refer back to if you are hearing some of these things and maybe are not familiar with them. The first one is Centers for Medicare and Medicaid Services. That is also known as CMS, probably most often referred to as CMS, and it's the federal agency responsible for the Medicare and Medicaid programs. It also has oversight of Marketplace and the CHIP program, the Children's Health Insurance Program, but the bulk of its work is in Medicare and Medicaid. I want to note too, we're still in the beginning, just in the first month of a new administration, and so a lot of the players in that administration are falling into place. Some of those require confirmation from the Senate, and some of those don't, but the head of CMS is somebody that does require confirmation from the Senate. And President Trump has nominated Seema Verma, to be the head of CMS, and she is about halfway through her Senate confirmation process. So she's still technically a nominee. I think the Senate will probably vote to confirm her soon. Of note, she has a Medicaid background, and this is the first administrator of CMS with a Medicaid background that we've seen in several years. We were talking yesterday, I think you might have to go back to the Clinton administration to find the last CMS administrator who really comes from the Medicaid world. I say that because I think we're probably going to be hearing, that means we'll probably be hearing a lot of these buzzwords even more often given her background. So the next thing, state plan, I would say that refers to the green rectangle, so the combination of the federal requirements and the state requirements make your state's Medicaid plan. That is where your state lays out how it's going to implement the Medicaid program in its state. With a plan, there has to be a way to change a plan, and there's something called a state plan amendment. That's considered to be a revision to the state plan. It's usually used to change things of more of an administrative nature, maybe the way that a provider's payment is working, as long as they have the authority to do so within the law. A state plan amendment, though, is different than a Medicaid waiver. And a Medicaid waiver is really an opportunity for a state to waive the federal requirements. So all of those requirements that are in the blue box, the mandatory populations or services, or the mandatory payment as such health insurance payment is, I think they were originally created to give states an alternative to look at ways to innovate in Medicaid and CHIP. And there are different types of waivers, 1115 waivers, 1915B waivers, 1915C waivers in Medicaid, among just a few, and there are lots of different rules. 1115 waiver is probably the one that you hear about most often, but I wanted to flag there are lots of different types. One thing I do want to note for you is we have a brand new resource, a waiver fact sheet, that just gives a little bit more detail about some of those rules and how each waiver type is used. If it's not live on our website in this very instant, it will be by the end of the day. So if you're interested in learning more about the types of waivers, definitely go and check that out. But wait till the end of the day, because I can't say for certain it's live right now. A couple more buzzwords I want to touch base on and give you a little bit of understanding for why these are buzzwords right now. There's currently not a limit on how much the federal government spends on Medicaid. So the FMAP is just a percentage. So as the cost of the Medicaid program increases, so does the federal share of that program. But there are a couple ideas being discussed right now that would limit the federal share of the Medicaid payment, and those two are block grant and then per capita cap or per capita allotment. Those two words are being used, or two terms are being used interchangeably. A block grant, pretty simply, is a grant to the states, a federal grant to the states to run its Medicaid program. So it's one lump sum that the federal government gives to the states and said, here you go, take this and run your Medicaid program. A per capita cap or per capita allotment is a set amount of funding that the federal government will spend per beneficiary that is then given to the state for their Medicaid program. So the difference between the two, the block grant would basically be one lump sum, and a per capita cap or allotment would be an amount that's determined per beneficiary. I think we're going to stop right here too. I'm curious to hear about what you're hearing on some of these buzzwords. Are these familiar words to you, or are there words that are coming up more frequently? So if you take a minute and let us know which ones you're familiar with, we'll take a few seconds to do another poll. Great. Luke, you can close that off, and we'll see sort of what folks are familiar with. Like I said, I think these are words that are probably being used in your state or have been used in your state in the past, but also you're probably seeing them in the news quite a bit as well. While we wait for those to be, oh, it looks like most of you are familiar with most of them, so that's excuse me, very good to know. And I'm very glad to see that the majority, it looks like CMS is by far the most popular of those words. So I think you're on the right track. But if you're not familiar, I hope that they give you a good definition to in context for what you're hearing. So those are the basics of Medicaid. I'm going to talk a little bit now about the basics of health centers. I think we all know what makes a health center, all of the requirements that we have under Section 330 of the Public Health Service Act. We must be open to all, regardless of ability to pay. We must offer our services on a sliding fee scale. It must be made up of a patient community or patient majority board, which I think makes us very, very unique. Those are definitely not all the requirements, but some of the most common ones that when we're talking about health centers, those are the ones that we reference most often. You probably have heard both of these terms, FQHC, Federally Qualified Health Center, and Community Health Center, and very well may use them interchangeably. I think in the context of Medicaid, though, it's important to know that there is a somewhat subtle distinction between the two. It's subtle, but I think it's very important. It puts a lot of this in context. A federally qualified health center, that's the term that if you were to sit down with the Social Security Act and go looking for health centers, you would see federally qualified health center. It's used by CMS and used in federal law to describe a health center that is either funded as a Section 330 grant or a look-alike, which means it is meeting all of the requirements of a Section 330 health center grant, but is not yet receiving funding, plus tribal and urban Indian clinics. Now, a community health center is a term that's found in the Public Health Service Act and one that we typically use to refer to health centers that are actually receiving Section 330 grant funding. Important to note the difference, which is the FQHC definition includes lookalikes, and the community health center definition does not. So around our office, a couple of us are known for saying that all community health centers are FQHCs because FQHCs includes everybody that's funded, but not all FQHCs are community health centers because there are some folks that fall under the FQHC definition that are not receiving the federal funding but are meeting each of the Section 330 requirements as if they were. I think it's really important to note the unique status. As in talking to health centers, I think we all recognize the work that health centers do on a daily basis. And it may seem normal because that's what you do on a daily basis, but it's important to know that F2HCs are the only provider type that have all of the requirements that we do. We're not able to turn away a patient based on their status. We're not able to stop taking Medicaid patients if we wanted to. And so I think that gives some important context as we talk about sort of how the PPS was created. In Medicaid, the federal Medicaid law requires states to, one, cover F2HC services. So again, they fall in that blue rectangle under the federal requirements, and not only cover them, but pay for them using a specific system. We're not paid like other providers in Medicaid, and that's by definition. Our payment and our services are specifically defined in federal law. This is important. Medicaid is very important to health centers. They make up nearly half of our patients, and we serve 1 in 6 Medicaid beneficiaries nationwide, which I think is something to really be proud of as a health center, to be able to say that overall community health centers serve 1 in 6 Medicaid beneficiaries. We're going to take another quick poll. I'm really keeping you on your toes during the webinar, but we're going to take another quick poll here and see sort of what is your Medicaid population look like at your health center, or if you're from a state, what does the state's health center Medicaid population look like, just to get a sense of where folks are. So I'll open that up for just a little bit and then have Luke close it in a little bit. You can go ahead and close it, Luke. While we wait for those to come in, we'll move to the next slide. So now we're getting into the prospective payment system. What is the prospective payment system, the PPS, and how did we get here? Where did it come from? Back in 2000, Congress took a look at health centers and said, we're providing them their Section 330 grant funding, and that is for the care for the uninsured. And we want to make sure that they're able to use that money for the care of the uninsured, and they don't have to make up for poor payments from Medicare or Medicaid. So we need to make sure that we're paying them appropriately under Medicaid. They created the F2HC PPS and the Medicare, Medicaid, and SCHIP Benefits Improvement and Protection Act of 2000, often known as BIPA. And that's important because the payment methodology is based on that year. The year of that is important because of how we base our payment, what year we base our payment on. Their intent, like I said, was to provide a consistent and predictable Medicaid reimbursement to ensure that we can appropriately use our grant funds to care for the uninsured. And today, I think it's essential to our delivery of high quality and cost-effective care. So what is it? How does it work? It's a single bundled rate that covers all of the services and supplies in a single visit. I think it's really important to note it is an alternative to paying under the fee schedule. This single bundled rate, it covers everything that a health center does. So we oftentimes give an example of a patient that comes in with a cold or minor condition and needs to be seen pretty quick, in and out, Medicaid patient. The health center would receive that single bundled rate. But if their next Medicaid patient that comes in the door is somebody that has, I don't know, 6 chronic conditions that the health center is helping them manage, on top of something else that has brought them in, it might be a visit that takes a little bit longer and the providers have to spend a little bit more time on. The health center would still receive that exact same bundled rate. It would cover all the services that are provided in that visit in both cases. It's not something where a health center has to add up everything that they do under this, like, a provider paid under the fee schedule. It's really supposed to be a comprehensive rate. So what's in the PPS and what's not in the PPS? You have to go to federal law to see, and we're talking about the federal requirements, so your states may have some additional services that they've included on here, but the federal definition is physician services, physician assistant services, nurse practitioner services, clinical psychologist services, clinical social worker services, and any services that are incident to those services, plus any other ambulatory services. The important thing to note, the ambulatory services part is there's no definition of that, so it's up to interpretation at this point. What's not included are things like your enabling services that you're required to provide as part of your 330 grant. Maybe your translation services. A lot of those services are not included in your PPS rate. And one very important thing that's not included in your PPS rate, we sometimes hear this, is it subsidizes the cost of my uninsured patients, and that is definitely not the case. The congressional intent of the Medicaid FQHC PPS was to ensure that you could use your 330 grant dollars more effectively to care for the uninsured, but the PPS was not created to provide care or to pay for care for the uninsured. So how is it calculated? Your initial rate, I said that the year was important of the passage of the law that included the PPS, 2000. Your initial PPS rate was created by establishing the average of 1999 and 2000, the reasonable costs in that. So you added up your reasonable cost for 1999, added in your reasonable cost for 2000, and divided that by the number of patient visits over those 2 years and found that initial PPS rate. It's calculated at each health center. So your health center in Des Moines, Iowa has its own unique PPS rate, and it's much different than the PPS rate for the health center in Washington, D.C. or Richmond, Virginia. They are unique to each health center, and it serves as a baseline payment, and that'll become more obvious as we continue to talk a little bit about this. New starts, some of you may be thinking, I wasn't around in 1999 and 2000, so I don't know how my rate was calculated. What was it based on? The law says that if you're a new start, you should look at neighboring health centers with similar caseloads, but if no similar health center exists, they can do a projected cost to figure that out. So worth knowing what year yours is based on. Are you a 1999-2000 health center whose rate may or may not have grown, or are you one that has come in later? Good to know just as you're thinking about this. So updating the PPS rate. How do we update the PPS rate? What's required and what's not required? The law says that for the years after 99 and 2000, it went into effect in 2001, so 2002 and beyond, the PPS rate should be updated by the Medicare Economic Index. Some states use a state-specific annual update mechanism. I think about 9 states are using one right now. But the Medicare Economic Index is something that's used across the board with providers, FQHCs and not. I think generally a lot of folks would have some complaints about the MEI, and in fact, way back right after the implementation of the PPS, the Government Accountability Office, the GAO, did a study on the implementation of the PPS to see how it was going and what could be learned so far. And they pointed to the MEI and they said, you know, the MEI is not really the best mechanism to update the FQHC services. It doesn't really reflect the FQHC service package very well, but quite honestly, it's the only thing out there, so it'll do. It's better than nothing. I think that's probably how folks still feel about it. I do want to just take a quick detour and let you know that in Medicare, as of January 1 this year, there's a new FQHC market basket that is used to update the Medicare payment for health centers. It was a little bit better than the MEI. It was showing a 1.8% increase versus a 1.2% increase for the MEI this year. So currently only used in Medicare, but just note that's something we could see in the future for Medicaid. You're also required to update the PPS with any change of scope in services, whether or not you're adding a Medicaid covered service or even, quite honestly, dropping a Medicaid covered service. If there are changes, if your program changes, they need to, your state needs to update your PPS rate accordingly. I will say that there's some guidance from the Centers for Medicare and Medicaid Services, but there's no federal definition in law with that. So we sort of see a mixed bag on that. Some states are really good at it, and some states are not as good at it. But coupled with the MEI that's not really keeping up quite as well with inflation and not specific to health centers, and then a mixed bag of change in scope, we're seeing that today the FQHC PPS rates reflect 82% of health center costs on average. So you're probably wondering, what if I'm in a Medicaid managed care state? I'm in a Medicare mindset apparently today. A Medicaid managed care state, how does this work? Because I know that a Medicaid managed care company may or may not offer you in a contract your straight PPS rate. When Congress created the PPS, they also had what's called the Medicaid FQHC PPS wraparound payment for this exact instance. They understood that the Medicaid managed care companies would likely offer a health center rates that were comparable to other providers in the area. In those instances, if that rate is less than the PPS rate, the state is required to come in and make up the difference between the Medicare managed care rate that is being paid to the health center and the PPS. Again, really taking the extra step to ensure that health centers receive their full FQHC PPS rate. So Congress has said, I'm going to make sure that you are paid the PPS, and then when in an instance of Medicaid managed care, I still want to make sure that the health center gets the full PPS rate. Some of you may be in a state that's Medicaid managed care and be discussing something called upfront RAP, or maybe some states are calling it a delegated RAP. Essentially what this is where the state comes in and says to the Medicaid managed care organization, I'm going to give you the full amount for the Medicaid FQHC PPS, and I'm going to make you responsible for that as the Medicaid managed care organization. So taking out the state responsibility to pay the difference and theoretically ensuring that the health center receives that full PPS rate from the managed care company. I think what's important for health centers and states that are considering this to understand is that and CMS recently released some guidance on this about a year ago in April that said if that's the case, it must be, every health center must agree to it before it's done. And I do think that the health centers, if this is something your state's considering, take a minute to talk to other states that have done it. Some have had good experiences and some have had not so good experiences. So to fully understand all the parameters is very important, I think, on that. Oh, there you go. My slide was stuck for a second. So some of you have said, maybe thinking, great, all this is wonderful, but I'm not paid the PPS, I'm paid something else, and you're telling me that there are federal requirements about what a health center must be paid under Medicaid, but you're also telling me that states have flexibility in some of those in developing their own Medicaid program. So how does all of this work together? And some of that comes from, some of that flexibility comes from something called an alternative payment methodology. So recognizing that there may be states that say, well, I'm not sure I want to pay it that way exactly, maybe it doesn't work with my system, like the actual mechanics of the PPS don't work with my system, or maybe I want to try out a new payment model, but how do I make sure I can include FQHCs under that because I have a requirement to pay them under this PPS? They said you can use something called an alternative payment methodology. There are two requirements under an alternative payment methodology. The total reimbursement to the health center must be at least equal to the PPS rate, and each participating health center must agree to the alternative payment methodology. So there are ways for states to examine some new and innovative models under the Medicaid FQHC PPS statute, federal law, but they do need to make sure that the health center is at least paid the PPS rate and that the health center agrees to it. I think this is another important piece of what Congress intended. So as we've seen, they created the PPS, they've thought of different scenarios. What about a state in Medicaid managed care? Yes, we want to make sure that they still are receiving their PPS. What about a state that may want to try a new and innovative model? Yes, we want to make sure they still receive at least their PPS rate. Really recognizing, I think, going back to that earlier slide, that health centers are unique and health centers have a different role in this environment than others do. Currently, there are 20 states that use an alternative payment methodology, and it really can look however your state wants it to look as long as those requirements are met. So throw that into the which state, which population, which service, and then which payment methodology are they looking at. So just note that those are requirements that you all have as health centers, that you must still be paid at least your PPS rate and you must agree to the APM. So those are a lot of the basics. We've covered sort of what is Medicaid and what our health centers and how our health centers, what role do health centers play in the Medicaid program, and then given you really a good overview, a high-level overview of what, how the PPS came about and how it functions, again, on the federal side of things. But we want to talk a little bit about common myths about the FQHC PPS. We oftentimes hear from folks these questions, these types of questions. Tell me about cost-based reimbursement and how health centers are paid via cost-based reimbursement. Or tell me about how you use your FQHC PPS rate to care for the uninsured. Or there's no flexibility in the PPS, or health centers are not efficient. Want to ask really quickly, are these questions, how many of these are questions that you have heard or statements have you heard before, or variations on these? I think we have a poll on that, Luke. Give you about 30 seconds, how about, to go through those and see. And we'll unpack each of them sort of one by one. Okay. We'll go ahead and close the poll and see what folks are hearing. Let's go ahead and we'll start with the first one. Health centers receive cost-based reimbursement. This is always the fun part of a webinar, because if we were in a room, I would ask you all to raise your hand if you have heard this before. I expect that some of you have. And if somebody asked me that question or sent that to me, what I would say was, no, we don't receive cost-based reimbursement. The FQHC PPS is derived from historical costs, but as we talked about with the Medicare Economic Index and inflation, and then changes in scope of services that health centers provide, it's definitely not cost-based reimbursement. It covers about 82% of health centers' costs for caring for Medicaid patients. In all reality, we started back way before 2000 with a form of cost-based reimbursement in Medicaid, but that is long gone, and for the past 17 years we've been working under the prospective payment system. So we definitely are not receiving cost-based reimbursement under Medicaid. And it sounds like that a large group of you have heard that one for sure. But the next one I think is one that we hear quite a bit, and that FQHC PPS helps health centers pay for the costs caring for the uninsured. I said it earlier, that is not included in your PPS cost. The care for uninsured is not included in your PPS cost. It is only reimbursement for Medicaid-covered services for Medicaid-covered patients, and it is not used to cover the care for the uninsured, but ensures that health centers can efficiently use their Section 330 grant dollars to care for the uninsured. I've said it a couple times, and I feel like I've said it again, so I hope it's something that everybody remembers from the webinar. But the PPS really is only, it's reimbursement for Medicaid-covered services for Medicaid-covered patients. And by definition, if you're uninsured, you are not covered by Medicaid. So with that, we will move on to the next one, which is health centers are not efficient and are too costly. It looks like, for those of you that answered, just about 34 folks have heard this one before. And I will say that there's a bunch of research on this that show health centers are very efficient and are not costly if you're looking at the facts, and talk about the quality of care that health centers provide. So if you're interested in that, there's a ton of information on that on our website. And I encourage you, if you're interested, to go dig a little bit further. But just some sort of high-level facts that I think are pretty compelling about health centers. We have lower utilization and spending compared to other Medicaid patients. There was a study that looked at 13 states and found that health centers saved on average $2,371 per patient. And overall, the healthcare costs are 24% lower than similar patients that don't go to a health center. I think that's very important to note. Also, if you're talking about, or if you're hearing about health centers being, quote, too costly, we account for less than 2% of total Medicaid spending, yet provide care to 16% of Medicaid enrollees. And I think maybe where this comes up is when we were talking earlier, I talked about the two examples of the patient, one with sort of a pretty quick and easy visit, and then one that might take a little bit longer. And I think sometimes the bundled rate is compared to other providers' rates without really taking into account all that a health center is doing in those visits, and maybe comparing a rate for the easy visit, which may seem to be a little bit more, while the other rate, you know, vice versa, for a more complex patient. So definitely a lot of really great studies out there that look at all that health centers have done, but I wanted to just flag for folks that overall we're less than 2% of total Medicaid spending nationwide. And then finally, the FQHC PPS prevents health centers for participating in state-based payment reform initiatives. I know there's a lot of conversation about state-based payment reform initiatives and how to get, I think everybody's looking at how to make sure that the system as a whole is paying for high quality and cost-effective care. We talked about alternative payment methodologies, and that's where this would come in. An alternative payment methodology gives the state flexibility to test a new and innovative model if they're interested, but also while maintaining that base payment for FQHCs that allow them to continue to provide care to their communities. So I think there definitely is a flexibility there if people are interested in pursuing that. If you're a state that does not currently have an alternative payment methodology and you're hearing that, the alternative payment methodology is a way for some of that flexibility there. With that, I want to talk really quickly about some resources that we have, and this is by far not an exhaustive list. I just want to let you know about some really helpful NAC resources. I mentioned there's a ton of research on health centers, and especially health centers and Medicaid. You can find more on that on our website. We also have a lot of fact sheets. We have a health center and Medicaid fact sheet. We have state-based fact sheets. We have a lot of different national profile available if you are interested in learning more. We're also putting together a lot of resources, like I mentioned, something on waivers, just to give a high-level overview of waivers and what they are and how they work. That will be available and whatnot. We're also providing updates from Capitol Hill and the administration. We do that through our website, but also through a newsletter. We have a ton of state resources, and especially a ton of state resources on Medicaid and PPS specifically. So if you've not checked out our state affairs section of our website, please take a minute to do so, because I think it would be helpful to all of you. Luke mentioned the MyNAC Learning Center. This webinar will be posted there, as well as all of our conference materials. I think you all may possibly know we have several conferences throughout a year. We always hope that you're able to join us in person, but if you're not, we post all of those materials on the MyNAC Learning Center. So if you're not familiar with that, please go take a peek, because I think it's a really unique and helpful resource for you out there. And then for those of you who are interested in learning more about this, I didn't go into much detail on where in the statute all of these requirements are housed. But if there is somebody out there that wants to take a peek at that, you certainly can. We have something called the FQHC PPS manual that goes into all of the details. It goes into more history. It goes into where the policies are. Are they in statute, or what CMS guidance has come out on that? So if that's something you're interested in, that's also available on our website as well. With that, I think I'm in it a little bit early, so I think we'll have time for questions. But I've also left you with my contact information. If you have any questions after the webinar, please feel free to give us a call. We're always happy to help and can help you work through any questions that you might have. So with that, let's see, Luke, I'm not sure what questions we've gotten so far. It looks like one question where it says, could you clarify about using PPS to pay for the uninsured? I want to make sure that folks understand that. So the PPS is used to only reimburse for Medicaid covered services for Medicaid covered individuals. If you have uninsured folks, you are and you're a federal grantee, you're using your Section 330 grant dollars to help cover the cost for the uninsured. But the Medicaid FQHC PPS is not used to cover the care for the uninsured. It's only for those Medicaid covered providers. There was a question about clinical psychologists, and be more specific about behavioral health providers that can bill for services. The law says at minimum the states must cover services by a clinical psychologist or a licensed clinical social worker. But if that's where it's going to be important to take a peek at your state Medicaid plan to understand what provider types they may have added there. They may have added different types of providers. We hear about that all the time, especially in behavioral health. And so it really does depend, but federal requirements are for clinical psychologists and licensed clinical social workers. Well, good question about, you'd like to quote the data provided on the percentage of health center costs that PPS rate reflect. That's from our Medicaid fact sheet, which you can find on the research section of our website at www.nac.org. Let's see what other questions have come in. Oh, this is a good question. Am I supposed to be doing something or taking action about the PPS change when I submit a change in scope request and go through that process? And I appreciate the question to help clarify that a little bit. There are actually two different kinds of change of scope. There's the change of scope that you do with HRSA, and then the change of scope process that your state would have in place for your Medicaid FQHC PPS. Because you may, as a 330 grantee, be providing services that, and adding services that may or may not be a Medicaid service. So it really does depend on the service, and it depends on what process your state may have in place for change in scope. So if it's a Medicaid service that you're adding as an FQHC to your service package, and you've gone through the HRSA change of scope and gotten that approved, and your state, say, has a change of scope process in place, then yes, you should be doing that. But if it is not a Medicaid covered service, then it wouldn't trigger a change in scope on the Medicaid side. I hope that makes sense, and if not, please send me a note, and I'm happy to talk about it a little bit further too. Let me see if there are other questions. Luke, I don't know if you've gotten any questions that have been sent to you directly.
Hey, Susan, it's Colleen. Another question, and I'm happy to take this if you're tired of talking, but how are PPS rates rebased? If it's not cost-based, then how is rebasing done?
Well, I can tell you, and Colleen, you can definitely jump in. It depends on your state, quite honestly. Some states have gone and rebased their PPS rates, and some states have not. It's not something that's consistent across the board. There's no federal definition on rebasing necessarily. Colleen, I don't know if you wanted to add something else to that.
Yes, and just wanted to say when they do rebase, they are supposed to rebase it on the full range, the cost, your reasonable cost for the full range of services. I think if rates were consistently updated and rebased to reflect changes in actual cost of services and the intensity of services, we wouldn't have the situation we have now where the rates are falling, noticeably behind actual cost. So if you have recently rebased rates, you should be in much better shape in terms of recouping a larger share of your actual cost.
Yes, for sure. And that's going to be something that it'll be definitely worth taking a peek at to see, are you a 99-2000 health center and are you still working off those 99-2000 rates? Or have you rebased? Or are you a new start, and if so, what are your rates based off of? That 82% is just based across, the national average that we've been able to find. Can FQHC PPS also bill for fee-for-service services, and how would we bill it? I can tell you that yes, and some of that is going to depend on what your state allows you to do and what services your state has added to your FQHC PPS rate. But if there are services outside and your state allows you to do that, then yes. How you bill it would be specific to your state, unfortunately. So I'm not sure exactly. You would do that as a traditional provider. That's how it works in Medicare. You have two numbers, an FQHC number and then a traditional provider number. Got a question, can a state lower an FQHC's PPS rate through a waiver process? And the answer is through a waiver, they can seek to waive the federal requirements, and the FQHC PPS is a federal requirement. So that's the answer there. I don't know, Colleen and Luke, do you see any others coming through?
Yes. We have a couple more, and I just wanted to add about when a state can lower your PPS rate. We also know of instances where states have had their PPS rates lowered when they had their rates rebased. Usually it had something to do around HIT costs and things like that. So that's the other time when you might see that. Another question we're getting here is the list of states who have an alternative payment mechanism, is that on the NAC website? I don't think we have that on the, yeah, is it? Okay.
Oh, well, I guess I should say, I know that we do an annual state survey, and I think some of that information is. I'll have to go back and check, but there's definitely information about alternative payment methodologies and PPS on the State Affairs website, so it may not be a list specifically, but may give you some more information there on the State Affairs section of our website.
And if you're a health center just looking to know what's up on your state, the contact person would be your PCA. And if you're a PCA person looking to know what's going on with other PCAs, check our website or contact our State Affairs or Susan or me or whomever, and we'll get you in touch with the right people. But there's a lot of activity going on around APMs right now. So another question, Susan, how about nutritional services provided by registered dietitians for FQHCs in Illinois? Are these reimbursable by Medicaid under the encounter rate? We unfortunately don't have that level of detail, but go ahead.
Yeah, well, that's exactly what I was just going to say. That'd be a great question for your primary care association or to take to your state Medicaid program. I'm not sure exactly off the top of my head how they're included in their state in the Illinois or really any state program. So we could definitely take a look at that and get back to you if you'd like us to. Or take it to your PCA.
Okay, you want to go ahead?
Yeah. If you have any more questions, please make sure to enter them into the chat box and select send to all panelists. In the meantime, we're going to go ahead and put a poll about how you felt about the technical assistance today, the training. So if you could just give us your feedback on that as well, and please send in your questions.
Yes, please, before you log off, please do that. We had another question, Susan, about the ruling out of District Court 9, so the 9th Circuit, about Medicaid coverage for adult dental services and FQHCs, and has CMS given a directive on this? I'm kind of blanking. I can't remember. Do you remember?
So
I don't think they have.
That's exactly what I was just going to say. I don't think that they have either. And I'm not sure that we will see one now.
Right, yeah, especially not now. So that leaves us in the current situation where adult dental services are not one of those services that are required by the feds. And so your state may require them, may include them as a covered benefit. So it really depends on your state. But there are states where, you know, Medicaid does not cover any adult dental, but Section 330 requires that you provide preventive dental, which is another example of why PPS rates won't cover full costs for Medicaid patients. Do you see anything else, Luke?
Not at the moment, no.
I think that's it that we see for questions here.
Oh, I will tell you, one that came in. Our slides available in a PDF or PowerPoint attachment. I think all the slides were emailed out before the webinar, but I will tell you we've had a heck of a day with our computer system today. So yeah, so our servers and everything. So if you don't have them, Luke, I'm thinking we can probably send them out again just to make sure folks have them. And the webinar will be recorded and available with the slides on the MyNAC Learning Center within the next 2 weeks. So if you're interested in going back and listening to it again and watching again, you can certainly do that.
Yeah, as Susan said, this is Luke Ertl. I sent out an email just confirming your registration for the webinar today. If you receive that email, inside you will find a PDF of those slides, and then again we will be sending it out here, hopefully not much more than a week, with the webinar recording and also those slides, if anyone would like a copy.
Great. Okay, I think that's it, right?
Okay.
Yep, thank you all for joining us today. Yep, go ahead, Luke.
Okay, and that concludes today's webinar. Thank you all for joining us, and have a great afternoon.
Thank you.